Okay. Thank you, guys, and welcome once again to our evening session on COPD. And it is very good to know that so many people are interested and is actually given their time towards the learning project. And yes, definitely, please, if everyone keep themselves muted and probably videos off as well, because that helps for the internet connection to work better and the slides to flow through smoothly. So along with me is got the same team, is myself and Dr. Menon, Mohamed, and Shivani. So each one of us will be presenting and try to upload the areas to see that we have a smooth transition right from primary, secondary, and definitely the medicine management team and the input from our management team of the. So I think as for the learning objectives, they still say the same. And this is us. And then if you go on the next slide, yes, so objectives would be is again diagnosis of the COPD, management of the COPD, how we can do in the primary care, sharing the templates for the primary care, and how is the list performing, and what are some of the targets for the PCN, and then we'll finish with inhaler technique and the questions. So with that, I will hand over to our consultant who has kindly given his time from his busy schedule. Is Dr. Menon, the show is yours. So please, would you enlighten us on the management of COPD as a learning? Thank you.
Thank you, Rami. I hope you can hear me. Yes. Thank you for inviting me to speak about COPD. I've just listed out the learning objectives. So the next 20 minutes, what I'd like to cover essentially is diagnosis of COPD, discuss some general principles of management, including the role of non-pharmacological intervention, which I think we tend to ignore. I think that's got a very important role in managing these patients. And lastly, just a brief discussion about how you manage an exacerbation in the community and prevent them from coming into hospital. We've got multiple guidelines for COPD. We've got the NICE guideline, which has been updated about 3-4 years ago, which is a very comprehensive guideline. It covers all aspects of diagnosis to management to hospital admission. Then we also have what we refer to as a GOLD guideline, which is an international guideline. GOLD stands for Global Strategy for Diagnosis, Management, Prevention of COPD. It's being followed by lots of institutions in the UK and around the world. It's also a very comprehensive guideline. But I think in terms of what I think would be very practical for our colleagues in primary care is the PCRS guideline. So PCRS is the Primary Care Respiratory Society guideline, which was published a couple of years ago. The guideline, all that glitters is not gold and not even nice. And then we kind of distilled all these guidelines together and came up with our own comprehensive prescribing guideline end of last year, which summarizes both a combination of gold and nice. So diagnosing the condition, I mean, the first thing to say, there's no single diagnostic test for COPD. You need a combination of history, risk factors, and spirometry to make the diagnosis. So typical symptoms, as you all know, breathlessness, wheeze, chronic cough, and sputum production. And you have risk factors. So in this part of the world, cigarette smoking is the major risk factor. But keep in mind that there are other risk factors which are relevant. So particularly in the developing world, exposure to indoor air pollution. So cooking in unventilated spaces is a risk factor. So that's particularly one of the reasons why a lot of women in sub-Saharan Africa, Asia, and South America develop COPD. There are certain occupations also that are at risk of developing COPD. So working in coal mining, silica factories, all this can increase the risk of having COPD. And lastly, you want spirometry. That's the gold standard test you want to do to make the diagnosis. So combination of symptoms, risk factors, and lung function. So traditionally, COPD has always been staged based on the spirometry. So in a patient with a post bronchodilator FEV1, FVC ratio less than 0.7 or 70%, you look at the FEV1 percentage predicted on its own. So that is based on the patient's age, height, ethnicity, etc. And a lot of the modern machines will automatically give you the corrections. Once you put the patient's data in, it will give you all that correction. And then obstructive ratio, and then you look at the FEV1 percentage predicted. And then if it is above 80%, you say it's mild COPD or gold stage 1. And if it's less than 30%, it's very severe, gold stage 4. The problem with this is that the severity of COPD based on spirometry doesn't necessarily correlate with patient symptoms. So I'm sure in your own clinical practice, you might find a lot of patients in mild to moderate COPD who are extremely symptomatic. They're in a hospital all the time, using a lot of rescue packs. So increasingly, I think it's been noted that lung function on its own is not a good indicator of patients, how the patient does. It's just an indicator of their lung function, but nothing more than that. Therefore, what has been proposed, certainly by GOLD, is you use what's known as ABCD assessment. So usually to help you guide treatment in patients. So the first step is you confirm the diagnosis doing a spirometer. So you have a post-bronchodilate FEV1 FVC ratio less than 0.7. That's the first step. And then the second step is you assess how severe the airflow limitation is. What I showed you on the previous slide. Is it mild? Is it moderate? Is it severe? Very severe. So that's the first step. Then the last step is you assess symptoms and risk of exacerbation. So how many exacerbations have they had in the last 12 months? How breathless are they? How disabled are they from their COPD? And that helps you guide treatment. And you can put them into 4 boxes, A, B, C, D, which I've highlighted on this slide. So this is a rough guide to initial pharmacological management. So at the bottom, you can see symptoms, and on the y-axis, exacerbation. So for example, you may have a patient who is not very symptomatic, only breathless on moderate to severe exertion. So they've got an MRC score between 0 and 1. And they haven't had that many exacerbations. So no exacerbations or less than 1 exacerbation in the last 1 year, they go into group A. So all they require is a bronchodilator. So it doesn't specify which one. Could be short acting, could be long acting. Then if they become more symptomatic, we go into group B. You may have to use a long acting bronchodilator. So group A and group B are basically patients who have minimal exacerbations. Then going on to the groups on the top end, group C and D, are the patients who have recurrent exacerbations. They had more than 2 exacerbations, or they had at least 1 hospital admission with a COPD exacerbation. Automatically they're high risk. And that group will require a slightly different approach. So if it's a group C patient, meaning exacerbations but not very symptomatic, you may start off initially with a long-acting muscarinic antagonist. And group D is a severe patient. So patients who are recurrent exacerbators who are very symptomatic. And for them, you may want to, the guidelines says you can go straight for LAMA, but in reality, most of them end up in a dual LABA-LAMA combination treatment or triple therapy. So that is the GOLD guideline, suggesting that you initially make the diagnosis, and then treatment is based on how symptomatic they are and based on number of exacerbations they get. So I'm just, so management is based on symptoms and exacerbations, but not lung function. And this, I've just highlighted the modified MRC dyspnea scale, which this is freely available on the internet. So you can, by asking just a few questions, you can get a rough feel of how breathless the patient is. So someone with MRC grade 0 would be, only get someone to get breathless from strenuous exercise. Whereas grade 4 patient is too breathless to leave the house, breathless while dressing or undressing. So that's grade 4. So those are more symptomatic. And another option is doing the COPD assessment test or tool, which again available freely, but it requires for you to go through, or the patient to fill in a questionnaire and answer questions ranging from how much cough do they have, how much sputum they produce, do they sleep well, do they have lots of energy. So, and the higher scores they give themselves, the more symptomatic they are. But in practice, the modified MRC score is good enough for you to have a rough assessment of how symptomatic the patient is. So managing stable COPD, you have pharmacological options and non-pharmacological options. Pharmacological options, bronchodilators are the mainstay because they help with managing the breathlessness. You have anti-inflammatory therapy, mainly in the form of inhaled corticosteroids, but not all patients are suitable. And then patients who meet the criteria for long-term oxygen, you give them oxygen. But remember, oxygen on its own is not a treatment for COPD, especially if they're only breathless. So the only reason to give oxygen if they're hypoxic on assessment. Non-pharmacological interventions, smoking cessation is key. At every opportunity, we need to try and encourage them to give up smoking, but in practice, it's quite challenging, quite difficult. Pulmonary rehabilitation is a evidence-based intervention that is still very much underutilized, and that is well known to improve patients' quality of life, symptoms, and also prevent hospital admission. So pulmonary, all patients who are symptomatic should be referred for pulmonary rehabilitation. Not to forget education and self-management. We give them rescue packs to encourage them to manage their COPD if possible on their own, and educate them on when and when not to use the rescue packs. Nutritional advice is important for people who are underweight, because being underweight in COPD is associated with poor outcomes. Vaccination also is extremely important. Again, encourage them to take annual flu jabs and pneumococcal vaccinations at least once after is important. Increasingly, we are sending some patients, selected patients, for surgical approaches to try and what we refer to as lung volume reduction surgery, which can improve symptoms. And then not to forget palliative care. So a lot of patients are end of life, and they have. It's important to signpost them to the palliative care services for symptom management. And the most important, really, among this is the bronchodilators and smoking cessation and pulmonary rehabilitation. I'm just going to briefly just focus on that for the next minute or so. So bronchodilators, you've got a variety of options. You've got short acting, you've got long acting, then you have combination LABA/LAMA combination inhalers, and you've got oral theophylline, which we've been used for many years, but their use has been started restricted because of side effects and interactions with various drugs. But some patients do benefit from having oral theophylline as well. Anti-inflammatory therapy, inhaled corticosteroids. So particularly, mainly indicated only in patients who have recurrent exacerbations, or in patients who've got asthma COPD overlap. That from those patients, inhaled corticosteroids are probably important and should not be withdrawn. And then triple therapy, patients who are on inhaled corticosteroids plus LABA plus LAMA. And the last few years, you've had triple therapy inhalers that have come out of the market, which are more kind of convenient to use for patients, 3-in-1 inhalers. Oral steroids are used mainly in the context of exacerbations, but not as a long-term therapy, except in a handful of cases in patients who are steroid dependent. So, but that will be an exception rather than the norm. A drug known as roflumilast is and again another anti-inflammatory therapy, can be used in patients who get recurrent exacerbations. But again, it's not widespread. It's not been used extensively in clinical practice. Azithromycin is a prophylactic antibiotic. You may have seen a lot of your patients, recurrent exacerbators on azithromycin. It seems to work quite well in ex-smokers who continue to exacerbate in terms of reducing the frequency of exacerbation. But patients should be counseled about side effects, mainly hearing loss, which can occur in a handful of patients. If that happens, it has to be stopped immediately. And then mucolytics help to reduce sputum viscosity and clear the chest and try and prevent exacerbations. Non-pharmacological interventions, I've said main thing is smoking cessation and pulmonary rehabilitation. So patients in group A, so if you remember we talked at the beginning, 4 groups. So group A patients are the low risk, not very symptomatic. Smokers, they should be encouraged to stop smoking, encourage physical activity, and they should all be encouraged to have flu and vaccination and pneumococcal vaccination. The other groups, again, smoking cessation is important, but pulmonary rehabilitation comes into it. So anyone who's symptomatic with breathlessness should be offered or referred for pulmonary rehabilitation. And obviously physical activity and vaccination are key in all groups of patients. This is is a slide from our local BHR guidelines that we adapted last year. So we got 4 groups, and we have given various options about what types of inhalers you can use in each of the different, depending on which category the patient falls. I mentioned about asthma COPD overlap. I think there is a big proportion of patients, certainly in our patch, who have this overlap syndrome. So typically these are patients in their 50s and 60s who've been smokers all their life, have had childhood asthma and bronchitis, and now they are behaving like COPD, but they do have an asthmatic component. So in those patients, it's important not to withdraw the inhaled corticosteroids. The Primary Care Respiratory Society have come up with a very simplified approach, keeping it simple approach management of COPD. Really 3 questions, is it a patient with COPD with a predominant symptom of breathlessness? Is it a patient whose predominant symptoms, main issues, exacerbations, or is it a patient with overlap? And depending on which category they fall into, you just follow that pathway. So if it's a patient with predominantly breathlessness, you want to give mainly bronchodilators, starting with a short-acting, long-acting, and dual LABA-LAMA combination. If you see there's no role of inhaled steroids in the patient who's predominantly breathless. Whereas if it's a patient who's mainly exacerbating, then you start off the long-acting bronchodilators and then move on to inhaled steroids at a later stage. And if it's a patient who's got an overlap syndrome, you definitely need inhaled steroids. Not to forget at each step, it's really important to ensure the patient is, having the inhaler technique is checked, ensure they adhere into it. You're focusing on smoking cessation and referring for pulmonary rehabilitation. Most cost-effective treatments in COPD. This is a pyramid of interventions. Starting at the ones at the bottom are the most cost-effective. So these have been. They've looked at what are the most cost-effective treatments for COPD based on quality-adjusted life years. So basically, the ones at the bottom are the most cost-effective. So flu vaccination, stopping smoking, pulmonary rehabilitation. So I would say all patients should have these 3 interventions at the bottom first, even before you consider starting pharmacotherapy, or at least they should be referred for these interventions before you start pharmacotherapy. Moving on to exacerbations. What is a COPD exacerbation? Again, it's a clinical diagnosis. And this is what is NICE's definition. So it's a sustained worsening of the patient's symptoms from her usual stable state and beyond the normal day-to-day variation. And that is acute in onset. And typically it is worsening breathlessness from baseline, worsening cough from the baseline cough with a change in sputum color and viscosity. That is typically a COPD exacerbation. And that necessitates a change in medication. So they need to have a rescue pack, they need to have antibiotics, they need more use of their bronchodilators. So that's a COPD exacerbation. But remember also, worsening breathlessness is not always due to an exacerbation. There may be other reasons why a patient a COPD patient may be more breathless. So they could have cardiac failure, they could have a pneumothorax, they could have a pulmonary embolus, they could have pneumonia. So all these things are worth keeping in mind when seeing the patient with a COPD exacerbation. And where do you manage these patients? If possible, you try and manage them at home, but not all patients are suitable for home management. So patients who are not suitable for home management are ones who are very severe breathless. If they're cyanosed, if their GCS is impaired, if they're already on home oxygen, if they've got social circumstances that are not conducive for them to manage at home. For example, they live on their own, they're not coping, they're confused, they've got lots of other comorbidities, they're quite hypoxic, they may not be suitable for home management, they may have to send them to hospital. But otherwise, a significant number could be managed at home with steroids and antibiotics and increased use of the bronchodilators. And what is the treatment? So it's mainly oral steroids, prednisone, 30 milligrams for 5 days. You give antibiotics if you suspect it's throat infection, and you give maximum dose of bronchodilator. And they need to be followed up and have a review a few days later to make sure that they've recovered from the acute event, and give them an action plan for subsequent exacerbations and ensure they're on optimal maintenance therapy. So that was just a quick run through of COPD management and exacerbation. Those are the learning objectives. Thank you very much. I'm going to stop sharing my screen for the next.
No. Thank you, Dr. Menon. That was quite informative. And actually, I did make the notes. I'm sure I will try to wrap it up towards the end of it as well. And please, can I just remind everyone to keep their audios off, because I think that does distract the person who's presenting. And so, Lewis, should we go to my slides just to give the primary care aspect to it? And
You're good to go.
okay, yeah, that's fine. So should we go on to the next slide? Yeah. So as we go and reflect back, yes, history, symptoms, objective testing. We have mentioned spirometry over here, but as Dr. Menon said, that it is all three which work in hand when you are diagnosing the person with COPD. Once you got the diagnosis, yes, we've gone through the symptoms. Why we go next straight to the smoking? Because how it was evident from Dr. Menon's presentation that these bottom three are the most cost effective. When we say bottom three, actually they form the foundation of the whole thing. So smoking and then pulmonary rehab, yes, we are aware of the waiting times, but I think that is in hand, so it is being worked upon. And getting all the readings, we have got spirometry up and running, educate the patient about the symptoms. If we as a GP, I'm sure we all know we got 10 minutes appointments, but every appointment try to go through the process and then followed up by our nursing colleagues or HCAs and even our clinical pharmacists, because they're going through the education and training process of managing COPD, asthma, along with the other long-term conditions. And as I highlighted last time, inhaler techniques and the BMI, because BMI is very important, not only from linked with the weight management, but it will also give you the criteria on the basis of working the patient towards the severity. Because if person is losing weight, yes, we think of red flags, but not to forget, is your patient so bad that he rather breathe than eat? So you might even need to get your nutrition into over there. You might need a referral to the nutritional team. We know there's a waiting time, but I think they are getting quite better at it, because I've referred few patients and I was pleasantly surprised. But they would need a nutrition supplement, because don't forget, COPD patient is breathing per minute more than us. It's almost like we having on a long marathon all the time. So should we go to the next slide? Yeah, this is just to give you a picture of the self-management plan. I think how we go through the levels. Yes, if I'm sure, as all the colleagues will remember, once you go through your COPD, the KEG template, it goes through all of these steps. Yes, we got CAT scoring, we got MRC, and just to make our life easier, Dr. Menon, we have got on the template, we just put the scoring 2 out of 5, 3 out of 5, and at the bottom, when we click a button, it calculates a score for us. So that is an IT making life easier and quicker. So please ensure that we are going through that and filling that, because that's what will help you should you move the patient to the next step. Exacerbations, if you remember, there is a block area comes over there where you have to fill how many exacerbations the person has had. And that is essential, because once you do that, it gets you to start thinking, okay, he's had 3 exacerbations. What have I done about the management? Or is he having more than 3? Do I need to start thinking about DEXA scans? He's already on high dose of inhaled steroids. So that is a reason why we say that it is good to have that as an overview and for you to actually categorize your patient. Inhaler technique, that definitely Mohamed is going to go and give us more enlightenment around it. And then BMI, already I mentioned, immunization, flu vaccine, and also I would emphasize over here pneumococcal vaccine, because pneumococcal, I know it always comes in small numbers, small batches, but please, whenever, wherever possible, ensure that the pneumococcal vaccine is also done along with when we are giving the flu vaccine. So then now on the left side, if you see, that's a self-management plan. Self-management plan, if anybody has a problem, please let us know, because when we were practicing this at the practice some time ago, one of my HCA could not bring it up. What should happen is once you finish the COPD template and you press save, it should automatically take you to the self-management plan, how it does in the asthma self-management plan. Over here, then it will ask you who is filling the form. You'll put in your details and it will take you to the form. So please, if it's not coming up for anyone, do get in touch with Shivani or the CAC team. We will be able to help, or even your practice manager would be able to resolve that issue. And definitely self-managed plan is something which we will try to work, because if you see, it says how many salbutamol, how many to be given maximum. What we will try to do is, if everybody feels comfortable as well, is to work up to give you some range on that. So it's myself, Dr. Menon, and my nursing colleagues, everyone knows Nora. So we will try to get something which, if possible, can autofill how it does for asthma. So that's something just to assure you that we will try to work on that. Should we go to the next slide? Okay. These are the effective management. Virtual monitoring, yes, wherever appropriate. We got video consultations. So yes, try to utilize. And then HCAs, pharmacists, very trained people. Again, I would say, please encourage them to have a conversation, especially your pharmacist colleagues from the PCN, and they will review the medications, and I'm sure they will help to up titrate the patients. Digital tool, again, similar like for asthma, you can send the self-management plan over to your patients after you have agreed with them. Template updates, and further down are some of the websites which you could share via Acrorex with your patients for their self-learning. Should we go next? Okay, this exactly like asthma, how we said, this is with the UCLP partners. So each of the long-term conditions has got the patients how you can
Two keys.
Is of high, medium, or low risk, and then you can align your workforce according to this. So please have a look at this and see where you can try to prioritize and arrange your workforce around it. And if you go the next slide, I think that should be going to Shivani. Yeah, this is COPD and Asthma LIS, and this is where Shivani will update us upon our performance and also the targets, what they were last year, what they're going to be this year, taking into account the winter pressures, and also we're coming out of the pandemic. And she will also update us on the performance, which can be available actually broken down to the PCN and the practice level, which your federations should be able to provide that. So Shivani, it's all yours.
Thank you, Dr. Hara. Hello, everybody. I'm just going to provide you guys some brief overview of the COPD Asthma LIS. As with the asthma part, COPD part of that list has been licensed June 2020. We are into the second year of the list. The COPD list basically has similar elements as the asthma. So we're talking about annual review for all COPD patients, talking about high-risk reviews of those patients. So you should have searches available on EMIS and other clinical systems to identify your high-risk patients, which are categorized based on certain clinical criteria. And in both the annual reviews and the high-risk reviews, the elements of review are quite similar, but they are slightly more encompassing and more holistic approach has been taken. The personalized action plan is one of the most key to that. And the expectation is while you are reviewing these patients, you're also carrying out things like your CAT score, your MRC scores, you're looking at the inhaler technique, you're ensuring that the smoking status is captured and a referral to smoking cessation is made if the patient has agreed to that. The vaccinations like the flu and pneumococcal are offered and provided to patients. Assessment for PR is made, and where appropriate, a referral has been made. So we are trying to ensure that all the patients are having a gold standard care to them provided. Now, the ask in terms of targets is that the expectation is at least 50% of the patients have had their high-risk reviews, and at least 50% of these patients have had their annual reviews. Just bear in mind, the annual review is over and above your cough elements. So it is much more than cough. And every practice that achieves higher than the target gets an additional benefit in terms of the PCN targets. And in the next slide, very briefly, I'll show you where the performance has been for last year. In terms of spirometry, spirometry is live in Barking and Dagenham and Havering. It is delivered via the Federation. So if you have any referrals for confirming diagnosis, please send them across to the Federations. The service is up and running currently in both the boroughs. Redbridge will go live pretty soon, and we will send out some sort of comms to all the Redbridge practices when it has gone live. The last element of the LIS is where we have opened up a training platform for all the clinicians and even non-clinicians to be able to register themselves and to be able to upskill themselves via that training platform. The training platform essentially covers similar items that we've gone through today in terms of diagnosis and management of COPD and asthma. It also enables you to learn about spirometry, and if you have an interest in getting an ARTP accreditation, that is also available. So I have put the site on there. So if you are interested, please do take advantage of this. This is only available for a limited time. So I would really encourage those who are interested to register there and benefit from this. Can we go on to the next slide? So this slide basically shows how the LIS has performed in the COPD aspect of it in last financial year. We've broken down the performance by borough and accumulated it across BHR. So you would see the yellow bars indicate the high-risk reviews that have been completed, and the blue bars indicate the number of plans that have been indicated. As it was quite a new LIS, I think practices were still getting used to it and still getting the idea of what were required of them. So you can see quite a significant amount of patients in BND and Redbridge have been reviewed, despite the fact that we were going through COVID and there were lots of constraints in delivering the LIS. A lot of good work has gone in already for the patients. And across BHR, at least 46% of high-risk patients have had their reviews completed, and about 40% have had their personalized action plan already completed and given to them. So this year we are saying continue the good work, continue doing what you are doing, continue reviewing these high-risk patients, and also do the annual review of all the patients that are on the cough register. So at the end of it, the impact of these reviews will be quite significantly seen in other parts of the health economy. It will also make the patients educated and make them confident in managing their conditions much better themselves. So thank you to all the team that have achieved such good results across BHR, and I'm sure at the end of this year we will see much better results coming out at the end of this financial year. Thank you.
Thank you, Shivani. I think, yeah, that is very encouraging, because especially I think during the difficult period, still overall reaching nearly 50%, 46% target is a good target. But yes, I would encourage everyone to carry on the good work, especially now when the winter is coming, and to ensure that especially the high risk, I would say, yes, now we are seeing patients face to face. So wherever possible, yes, we use the technology, but at the same time, how Dr. Menon highlighted that some of these patients could be having other comorbidities. So we just do as per our clinical assessment. So that's what I would encourage on the clinical triage. So now going on to our inhaler technique, inhaler expert, Mohamed, it's all yours to get us to be more learned on the inhaler techniques. Thank you.
Thanks, Dr. Hara, for that compliment, but I would just say that it's just sharing some experiences and just reminding ourselves what we all already know, actually. So I won't claim to be teaching anybody anything, but what I'll do first thing is to try to actually share the screen and see if that's actually going to work on this occasion, actually. So here we go, right? And seems to have worked this time. Okay, that's great. See if I can actually move them. I'll sort of cite the slideshow and start working on it. Okay, right. Okay, sorry, I've gone to the wrong place here. So I need to get to where we are. Okay, sorry, just move along and move to where I was. Okay, that's great. So we'll start with a patient that I recently saw. It was a patient, 8-year-old with COPD. I won't go into all the details, just cover the bits about inhalers. So patient on salbutamol, MDI, 2 puffs twice a day, using 2 per month, Relvar-Ellipta, 92, 1 puff daily, Sebree, breezhaler, 1 puff daily, and Filocontin 225, 1 twice a day. I was asked to see the patient because the doctor wanted an alternative to the Filocontin. What do we do? So I thought before we start going into Unifilin and another theophylline, let's actually examine the technique. So I asked the patient, show me how you use your salbutamol. So he said, okay, I use it. What I'll do, I'll stop sharing screens now so you can actually watch me with it. So hopefully you can see me. I can see a big doctor. Can you see me big across the screen? Can you see everything across? Can everybody see me there? I can see a big thing saying Dr. Hara, actually. Yeah, okay, that's fine. Okay, great, wonderful. So, okay, so I asked him, show me how you use your sub. So he said, sometimes, look, I use it with the spacer. Sometimes I don't, because I don't have one upstairs. How do you use it? Okay, I just go. And it was a very shallow breath that he showed me with the spacer, because that's all he thought was needed. We then said, okay, how do you use your Sebree? So, okay, well, fortunately, what he was able to show me is that he was able to open it up, which was good. The Sebree is the llama, by the way, and open up the capsule. At least he put it in the right place. He didn't put it through the nozzle. We sometimes see patients put it actually through the nozzle. So he opened it. He inserted the capsule. He actually crushed it as well, which a lot of people don't do. And then he went. That's it. That was done, basically. Okay, so that was his Sebree. And this is a patient on Unifilin, very breathless, and who needed to go on to an alternative to the Unifilin. And then lastly, the Ellipta, the Relvar-Ellipta. Okay, he managed to open it. And again, he showed me a very shallow breath. So effectively, the bottom line was that he was not really benefiting from his inhalers at all. And the importance of technique is just something that we must check each and every time. Even if we have done it before, even if we've shown them before, it's something that we really have to spend the time to actually watch them do it and see if they're doing it properly, because there's so much to be gained out of getting the right inhaler to the right patient. So anyway, I showed him how to do it properly, which was to try to use the salbutamol as a tidal breath. It really works very well with COPD patients, who many of them are at home, so that they've got the space to have the spacer, and they have the time to do tidal breathing. So effectively, and it's especially good with the aero chamber flow view, because you can watch this particular thing go up and down, actually. So effectively, and I tell them, look, you need to get it deep in their lungs. It's not a case of getting it in the mouth, getting it in the airways. It's actually to get it deep, and you'll actually feel the difference there. So effectively, it's a case of 5 nice deep breaths. And he noticed the difference himself. With the Sebree, what really needed to happen is that he needed to hear a big noise, actually. He needed it to continue. The key thing about dry powder inhalers is, in fact, about all inhalers, is they must breathe deeply to get it deep into the lungs. With dry powder inhalers, it is a deep and a forceful breath. With MDIs, it is a deep and a gentle breath. And with the soft mist inhalers, again, it's a deep and a gentle breath. So effectively, that's what he should have been doing, but he was doing. I asked him to also actually see, when he opened his CBRI after doing it, whether there was powder left in the capsule. And he said, yeah, I observed the powder was left, but I just thought that's the excipients, you know, that's what it was. Actually, he never thought much of it. And then the Relvar Ellipta. Now, the Ellipta range is very strongly promoted because it has got LAMA, LAMA-LABA, ICS, triple therapy. So very convenient for the patient to use one device across. But the issue with it is, there are two issues with it, and there are many, but two issues. One is that it's once a day. So if the patient is only taking a triple therapy or even his Relvar once a day, and they manage to just do a shallow breath, well, they've had nothing all day in terms of ICS or LABA or LABA. And secondly, there's no feedback. At least with the CBRI, we got that feedback. We heard the noise. We could see the capsule here. You got no idea whether the patient's got it into the lungs, whether it's helped them or not, which is why before starting patients on the Ellipta or on any other dry powder inhaler that does not have feedback, that doesn't tell you whether you're getting it in, is to use an inject device, which I know a lot of people don't have, but it's well worth investing in. It's 25 pounds, but it's worth its weight in gold, because then you can set the resistance to the resistance of the dry powder inhaler that you want to give them, which in this case would be medium for the Ellipta, and get them to breathe in, pretend it's the inhaler and breathe in. And in this person's case, they only had a flow rate of 20 liters per minute, which was not enough to breathe in the Ellipta anyway. So in the end, what we decided, we had a discussion with the patient, and we agreed the patient would be would sort of use the salbutamol. I give you an extra spacer, one for upstairs, one for downstairs. You know, we want to rate people by how many spaces they prescribe. The more, the better it is, actually. And in terms of the triple therapy, we just decided to go for triple therapy, but to go for an MDI. Now, I know the target is to move towards dry powder inhalers, but the most expensive inhaler, the worst one, is the one that the patient can't use. So in this case, the patient was very happy to receive an MDI, Trimbo triple therapy. We could have used Trahixo as well, which is also triple therapy now, MDI. And the patient was going to use tidal breathing, because he was quite happy to use it, and he was noticing the difference. So we'll go back to sharing the screen again. And hopefully this time I will get it right. Okay, there we go, and share. And move on with the next bit. Okay, is it moving? Is it stopped moving? Oh no, I have to start the presentation on current slide. Okay, that's fine. Okay, so effectively, we've got a lot of weapons with COPD. We just need to make sure that they fire and we use them properly. So effectively, the 3 R's are the key with inhalers. Use the right inhaler for the right patient with the right technique. Whilst there may be a target towards dry powder inhalers, the target this year, the national target, is to try to move towards less than 45% MDIs, non-salbutamol. Next year will be 35, then 25, but only if it's appropriate and only if we have checked that the patient's using it properly. The inspiration with all inhalers needs to be deep, and that's what a lot of patients don't do, to breathe it in deep enough. With MDIs and SMIs, it's deep and gentle. With dry powder inhalers, it is deep and either hard, forceful, fast, whichever words you want to use, but the deep has to be there in all cases. With dry powder inhalers, there's so many of them, you must make sure that they have the right inspiratory capacity. One thing that concerns me a lot is that there are now a lot of generic tiotropium inhalers around. They look awfully like Spiriva. So you've got Spiriva itself. You've got Braltus. So Spiriva is 30 pounds, Braltus is 26. Then you've got the Glenmark version, which is the Tiogiva, which has been launched at 20 pounds. Great, we might say, but high resistance. And again, the problem with all these tiotropium generally is that they have high resistance. A lot of, when we test it out, we do workshops, a lot of GPs and nurses and pharmacists don't have enough inspiration to breathe that in. So how do we expect the patients to be doing that? So if they work, fine, if they've got enough inspiration. And then we have to make sure that there is a feedback, or we have checked with the incheck dial that they've got enough inspiration. Can the patient prepare the inhaler? So one of the most beautiful inhalers is the soft mist inhaler. And you've got Laba Lama in there, which is Spiolto. You've got Lama in there, which is Spiriva. But to make it up, normally when we ask people to make it up at workshops, pharmacists, GPs, nurses fail, because the idea here is you get these two, you have to open it up, you have to insert to bang it to make sure it's right. You then have to click it back. You then have to twist it, and you have to prime it by using it 3 times. You can actually see that. Now, that is something that you must make sure that the patient knows what to do, or you make sure that you write on the prescription, pharmacist, please make it, and maybe even give them a call to make sure that they're making it up. Far as spacers are concerned, please do prescribe them with MDIs. No MDI should ever be prescribed without a spacer. People can have 2 if they want and use it in different locations. There is obviously the classic, the aero chamber, but the flow view aero chamber has got the little dial so you can see if they are, when they are breathing in. But another nice new one, which you may have seen, is for those people who don't want to walk around with a spacer, is this A2A spacer, tiny. And effectively, it can be made up, and any of the inhalers will fit in there. Tidal breathing is best. Please check technique every time because it's easily forgotten. Now, that has been a very, very quick tour of the inhaler technique. What we are going to do, because of the targets, etc., we're going to do a lot more information about technique and types of inhalers, which inhalers to use. So many new ones have been launched now. There's an entire breathhaler range now. So we'll cover it partially in the prescribing forums. Those are going to be on the 25th of October or the 3rd of November. The whole session won't be on inhalers. There'll be other prescribing updates, but inhalers and the latest targets will be part of it. But we are also going to organize, and if you need to attend that, then please email one of those 2 emails. But also we're going to do an extra workshop exclusively for inhalers. And we are really very lucky because Dr. Hara and Dr. Menon are both going to attend it. The date has just been decided, 8th of December, 2021. I'm sure Bola will be sending out the invites to everybody. I hope you're interested, but please put down what you would like covered in that workshop within the chat box, or email it over to any of us, Louise, Bola, myself, Dr. Menon, Dr. Hara, what you would like to get covered within the within that workshop. So 8th of December. Thank you very much. I'll stop sharing screens now.
Thank you, Mohamed. That was really, really good update. And I think it is every time we are learning new things. And I'm just, before we go to the questions, I would like to just quickly summarize a few of my personal learning points, which I picked up. Is one is from Dr. Menon's presentation, is that not only remember the occupational hazards, but also somebody who has comes for as a first generation from one of the developing countries to remember about the biofuels, what they would have been exposed to. So that is always good to remember. Then also the ABCD criteria, and third is your quality, because not to forget your flu, pneumo, and the pulmonary rehab, and especially pulmonary rehab for somebody who's having repeated exacerbations. And as for definitely for azathioprine, I think that mainly comes from the consultant advice. So that is something, again, if any questions, I would say, please speak to the respiratory team. And from the inhaler technique, again, perfect, really good, as always, Mohamed, telling the patients how to take the inhalers, not to waste the inhaler. And also, it's always good to use the spacer. I really like that one as well, especially in children, because the indicator reassures the moms as well that the child is taking the inhaler right, because you see the little marker stay down as they do it. And from personal point of view, I usually tell the patients that, will you drive fast around a bend? Your neck is a bend. So, you know, if you go fast, you're going to crash. So MDIs, remember, it's a rainy day. And when you're dry powder, you're driving over a sand dune. So you go deep and strong. And then the rainy day, you go, yes, on the slow and steady because you're going around the bend. So that's my just way of telling them you're driving around the bend. That's how your inhaler is going. So taking no more time, should we go to the questions? Lois, do you have any questions on the chat? Would you be able to bring those up, please? Or anyone has raised their hand?
There's some questions around the referral form and whether that's been sent out to all of the GP practices.
Yes, I think it's the referral forms. We're talking about the spirometry. Yes, the Federation has sent the forms. Shivani, any update if any practice does not have it?
So I think the question is specifically for Havering. Just to give an update, the Havering spirometry is delivered by Havering Federation. So if you're looking for a referral form, it is Havering Federation. But a word of warning, Havering Federation have taken on a massive backlog from BHRUT. So they are focusing on completing that backlog before they openly accept new referrals. But Havering Health will be your point of contact for any referrals for spirometry.
Thank you, Shivani. And I think the slides will be shared. That was another question. Oh, they definitely will share all the slides. Anything else? Any other question which I'm missing?
Earlier on, somebody had their hand up, so I don't know if that person wants to now come in and ask either Dr. Menon or Dr. Hara or Mohamed a question directly, or Shivani.
There's a question around copy of BHR COPD guidelines. I don't know if that exists.
It does actually. I can send it. I can send it to Louise.
Dr. Menon, that's very kind. They're already on the medicines management pages of the website, actually. So they're already on there.
On the intranet, you know,
Yep.
So when the GP intranet, you go to medicine management, when you break down to the disease specific, like how we have for genitourinary and all the different things, you can go onto that one as well.
Dr. Hara, you did a better job than me. Thank you very much. We can see that it's being used actively. Thank you very much.
So there's a message directly as well for Dr. Menon on advice on the COPD cough management. And what can you advise when all sinister etiology has been excluded?
Yes, I'm afraid so. I mean, eventually in practice, you'll end up doing a CT scan in these patients to make sure they don't have lung cancer, because they're at high risk of having lung cancer. The other thing is, it's very common, as with all these chronic coughs, acid reflux is a common issue. A lot of patients have got lot of upper airway problems, sinusitis, rhinitis, and that's also an issue. Thirdly, especially the obese patients always think of sleep apnea, which can also present with cough and nocturnal symptoms. So, and obviously when you do a CT scan, some of these patients also have bronchiectasis. Up to 30% of these patients have coexisting bronchiectasis, which also cause a chronic cough. So yeah, I think once you've done the CT scan and there's no cancer, then you just have to manage it accordingly. Sometimes you just put it down as a smoker's cough. That's right.
There's another question around an asthma checks and asthma information. We actually provided a webinar 2 weeks ago, and that will be recorded. It'll be available on the CPEN pages. So Bola should be able to share with you where you can find the last talk. And then we've got the next one at the beginning of December, as Mohamed said. So he'll be able to go through a little bit more around the LAMA and the LABA at that time, hopefully.
And just back to how it works, the roles are all different. Strength people in the team. So if your strength is communication and like talking to clients, then we're all well and good. So that you would work according to
Thanks, Bola.
So nobody has put down anything that they would like to cover at the next session. So perhaps they don't want another session, it looks like, actually. So it would be nice to get some feedback on that. You know, what would they like covered?